as you're looking at any area that you're going to draw blood from for a venipuncture, be it the antecubital fossa, be it the dorsal metacarpal veins on the back of the hand, there are a couple of words that I want you to have in mind. One is called inspection. Inspection just means simply to look or to observe. And I always want you to look at the arm and observe the arm or the back of the hand for any trauma, for any discoloration, for any cyanosis, any bluish discoloration, any burns, any deformities. Because if there is something like that going on, you as a phlebotomist should really choose another site. You should never use sites that are burned, that are traumatized, that are deformed in any way. The other thing that I want you to keep in mind is always ask the patient and look at their chart to make sure that they've had no mastectomies or lumpectomies or some type of surgeries on the side that you're drawing from. If they have, always choose the opposite side. So inspection means to observe, to look. The other thing you need to do is not just look, but feel, to touch. I have students coming up to me all the time going, I don't see anything. And I go, really? And we go over and we put the tourniquet on, and then I feel a big little knot right here, and I go, geez, what is this? Because I'm not able to always observe a vein, but I'm able to touch it. I'm able to feel it. And touching it and feeling it is called palpation. And so by inspection and palpation, we're observing the veins of either the antecubital fossa or the dorsal metacarpal veins on the back of the hand. At this point, we're ready to do the actual venipuncture, and I'm going to demonstrate this first venipuncture on the arm. But before I get there, just want to mention a couple things. Number one, notice that I have goggles on. Glasses are not part of your personal protective equipment. You need to have appropriate OSHA-approved goggles on to prevent any splashes or sprays. Anytime you're dealing with any pathogen that has that potential for a droplet or a splash or a spray. You also need to have gloves on. And those gloves, once again, notice these are colored gray or blue or whatever color, but they're not yellow. They're not latex. I should also have a protective gown on. But for the purposes of this demonstration, just realize that you probably see one on to protect my clothing. So goggles, gloves, and gown are part of your personal protective equipment. They are not optional. They are not for your debate. They are there to protect you and to also protect the patient. Because, I mean, if I come in with a laceration or some abrasions on my hand or my fingers and I do this venipuncture on the patient, again, cross-contamination is a big thing. And patients walk away from the hospitals or doctor's offices or clinics with nosocomial infections, hospital and institutional acquired infections. They never had it when they walked in there, but we sure have given it to them when they leave. And we want to prevent that at all costs. We're now ready to perform our draw, and let me just make a couple of introductory statements on this. Number one, patient position is a very, very important issue. Extremely important. If you notice Veronica's position here, she's just a little bit back from the desk, and if this were actually her arm, I would have her scoot closer to me. Because if she becomes unconscious, she passes out, she goes into a syncopal episode or fainting, I'm not going to be able to jump across this desk and try to break her fall unless she's very, very close. The other thing you want to be very cognizant of is that if you ever have a patient that tells you, geez, you know, I really don't like this, use a little bit of clarification. Clarification is very, very important in communication, especially in the medical field. You need to clarify what the patient means. Why don't you like this? What are you saying you don't like this? What is it about this procedure that brings you fear? Okay, and if they ever say this, well, I've passed out a couple of times, you will not draw the patient in this position, the patient that Veronica's in right now. You will draw them in a supine position, which means they're on a gurney and they're face up, okay? Because if they pass out, there's no way now that you can break their fall. This position that Veronica's in right now, kind of a seated position, we call a Fowler's, F-O-W-L-E-R-S, Fowler's position. The other thing important about this position is that the arm be in a slightly downward position. It should not just be horizontal. And the reason is because if I take a test tube like this and I insert it in the vacutainer holder and the arm is in this horizontal position, then this inner needle that is going to puncture the top of this test tube is going to be able to collect any type of anticoagulant in this tube. And just now, the needle can carry over the anticoagulant from one tube to the next by the arm being in this position. But if the patient takes their other fist, doubles it up, puts it underneath their elbow, to where the arm is in a slightly, notice, downward position, and you draw the blood, then the tube, as you're drawing it, will fill from the bottom up. And this is kind of a buzz phrase that I use. And you want it to fill from the bottom up because the blood will stop running before it ever gets to the top of the tube. There is always a predetermined vacuum in each tube. And the blood stops running before it goes to the top of the tube, and therefore it never touches the needle. And the needle cannot carry over the anticoagulant from one tube to the next. So, a couple of things here. The arm needs to be in a slightly downward position. The patient needs to be very close and proximal to the table. You need to make the patient feel comfortable. You need to introduce yourself to the patient. You need to make sure that you properly identify the patient. And the best way to do that is to ask the patient their name, but not just their first, their last name, their middle name. And you need to compare what the patient tells you to the doctor's order. The other way is by looking at a wristband that may be on a patient. If they're an inpatient, you need to compare the number, the medical record number on that wristband to your order. Another way to do it, according to CLSI, is even asking the patient their address. You need to make sure you've got the right patient and that you're doing the right procedure on that patient. So we're going to kind of play here a little bit, like the arm is in a slightly downward position. Notice that everything is arranged, and before I place this tourniquet on, all of my equipment is assembled. Because the tourniquet, once it's placed, should not be on for longer than 1 minute. Once again, a tourniquet should not be on for longer than 1 minute. And if I put a tourniquet on and then I have to go back and reassemble my equipment and rearrange my tubes in the order of draw, or maybe I forgot some 2x2s or some alcohol, then that's just additional time. And let me tell you what happens. With that additional time that the tourniquet is on above the antecubital fossa, and by the way, when we place this, we want to place it approximately 3 to 4 inches above this antecubital fossa. Notice where my finger is here. About 3 to 4 inches above, in a superior position, the antecubital fossa. And it should be on no longer than 1 minute. If it's on longer than 1 minute, it can cause something called hemoconcentration. And hemoconcentration is the blood becomes very thick. Small particles that are in the blood efflux. They go through the vasculature, the blood vessel, out into the tissue spaces. And the test results are skewed. They're wrong. So do not leave that tourniquet on. The other thing is, if you leave the tourniquet on longer than 1 minute, it causes additional pain to the patient. So once again, all of the equipment is assembled. Everything's ready to go when you put the tourniquet on. One of the most essential things before you even begin this procedure is tourniquet placement. And a lot of students have no idea how to place a tourniquet appropriately. I'm right-handed. I want you to watch this technique. I'm simply going to lay a very, very short piece of tourniquet about 3 to 4 inches above the antecubital fossa. And I have that short piece facing me. I'm going to take the long piece here and place it in my right hand. It's my right hand holding the long piece. I'm going to put my left hand under the short piece. Again, remember that I'm right-handed. I'm going to come right about here. And I'm not going to try to tie a knot. I'm just simply going to lift straight up with a little bit of pressure. Because if you put this on too loose, there's no point in it at all. And I'm simply going to cross up and over. And then I'm going to put my thumb down right here where the two pieces of tourniquet cross each other. And I'm going to either use my index finger here, or I like to reach up with my middle finger and just simply run a small section under so that the tourniquet, notice now, is flat, it's tight, it's above the antecubital fossa. And it doesn't look like this. It's not all rolled up, cutting into the patient's arm and cutting into their tissues. So what I tell students is get used to putting your tourniquets on. And I think every one of you that are watching this video should practice. How much? I would think about 60 to 100 times putting tourniquets on different people's arms. I would stick with adults normally, okay? Somebody that's not going to walk out and call Larry Parker right away, but stick with some adults so you get used to putting the tourniquets on. Once again, I have a short piece facing me. I have a long piece here. My left hand is under the short piece. My right hand is on the long piece. I'm about the middle of this long piece. I lift straight up with a little bit of pressure. I cross up and over. I put my thumb down. And then I reach up with my middle finger, or I can use this one right here, and I make just a slight tuck. You don't want to make a large one, because if you make a large one, when you go to try to release the tourniquet, it may not come off. Placing this tourniquet 3 to 4 inches above this antecubital fossa does a couple of things. Number one, it causes venous distension, which means that blood begins to fill the veins. And it also causes some venous congestion, which means the veins begin to kind of pop out, so that you can do two things. That you may be able to inspect and see the vein, not in all cases, but in some, and you may be able to palpate and feel them. And I always tell my students, when you feel the veins, don't just go like this, okay? Take your index finger and run it along the length of the vein, looking for the direction of the vein. In other words, how much vein do you have available, okay, to insert the needle? Roll your finger gently to the side. Make sure that the vein is wide enough for you to insert the needle, that it's not necessarily just the first blue thing that pops up. That may be a venial, which is a very small vein. And this needle, this 21 gauge needle, would not be able to insert within the lumen or the anterior of a venial. It's too small. So make sure your vein is large enough. Look for the direction. Notice how I'm placing my body. I've got my body so the vein is almost cutting my body in half here. And I'm palpating it. I'm feeling the direction. I'm rolling my finger to the side and feeling the width of it. The other thing I do is press down. And I leave my index finger there for a few seconds. You probably say, well, why are you doing that? I'm feeling for a pulse, because once again, the brachial artery could be in the area that you're drawing blood. And if you feel a pulsation, it's not a vein, it's an artery. And you want to avoid arteries at all costs. Once I have inspected, I've looked, I've observed, I palpated the direction of my vein, I'm going to pick up my appropriate prep solution, which is, again, usually speaking, 70% isopropyl alcohol. I'm going to rip the alcohol open. Now, I'm probably the only instructor that does this, but they say that when you prep an area, that you should prep from the center to the periphery. This is changing in regard to some prep solutions, but it's still in the textbooks. And so if you're going to prep from the center to the periphery, notice the size of this alcohol pad. If I just sit here and go like this is not centered to periphery. This is just staying in the center. So what I tell my students to do is fold the alcohol into quarters. And then start in the center like this and make small circles. Small concentric circles coming out to the periphery with each circle, so that you're prepping from the center out to the periphery and never come from the periphery back in. You'll see some people, when they draw your blood, simply go like this. back and forth. That is not center to periphery. You'll see other people prep the area correctly, and then they'll take a 2x2 and pick it up and try to dry it. These 2x2s are not sterile. Your gloves are not sterile. You just simply recontaminate the area if I start up here and start pulling down to try to dry the area, because I move pathogens from here right back over my area again. So center to periphery. Notice I'm now going to bring my tubes in an area that I am going to be able to pick them up. And because I'm right-handed, I'm going to pick up this whole setup and I'm going to move it over here because it's easier for me to grab tubes on this side. I am now going to pick up my vacutainer holder with my multi-sample needle on it. And what I need to do, if you remember from your textbook, the bevel of the needle, the slanted part of the needle, always needs to be up when it's inserted. And usually, not with all multi-sample needles, but usually, if I put 2 fingers on the bottom, right here, and I put my thumb on top, right under the OSHA-approved safety device, and I roll these 2 fingers in. In other words, I've got my index and my middle finger on the bottom, 2 fingers on the bottom, and I've got my thumb on the top. And notice where I've placed them, all the way to the end of this hub. And these 2 fingers are rolled in. I want these 2 fingers are rolled in so that I can eventually grab the flanges right here and engage the tube without shoving the tube in. I'm now going to put my vacutainer holder and my multi-sample needle down, and I'm going to grab the needle right here, right at the distal end of the cap, and I'm going to pull off. Notice what happens. When I rotate my needle back up, the hub, or the slanted part that is, the bevel, is always up. It is always up if I take the cap off like this. When I rotate my hand up, my thumb is usually in the position of the bevel, meaning the bevel is up. And now I'm ready to do my draw. When I do my draw, I'm going to come over like this to the patient's arm. I'm going to, with my non-dominant hand, with my left hand, come way down here and retract the skin towards me. And the reason I'm pulling it towards me is that I stabilize the vein from rolling, and the needle insertion is a little bit easier. So this is called retraction. I pull the skin towards me, and then at a 15 to 30 degree angle with the bevel up, 15 to 30 degree angle, I'm gently going to enter the vein. And as I enter the vein, when the bevel disappears, I probably want to stop unless the vein is a little bit deeper. I then grab my tubes in the order of drop and I have it labeled down. And the reason you want it labeled down is because you notice blood being able to come into the tube. With the label up, you can really not see the blood being drawn into the tube. So make sure the label's down. Notice also that the needle and the vacutainer holder is stabilized against the patient's arm. It's stabilized by my index and my middle finger against the patient's arm and my thumb on top. It is not just out here in space trying to hold it, because I could easily push it in or pull it out. So it's stabilized against the patient's arm, okay, and it is not moving. Notice I pick up my tube, I lay it into the vacutainer holder. Do not try to just shove the tube in, because you can place the needle in further with that type of maneuver. What I do is I use these flanges here on the hub or the vacutainer holder. And I take my index finger and my middle finger and I lay them on the flanges, just gently. And I take my thumb and I put it to the back of the tube. And I engage the tube by pressing it in and pressure between my index and my middle finger and my thumb. Again, the action is not just shoving the tube in. It is using the flanges here with my thumb and my middle finger, and my thumb pressing and engaging the tube in. The tube then will fill from the bottom up if the arm is in a slightly downward position. When the tube is completely filled, you want to take your middle finger and your thumb, put it on the tube just like this, and pinch it. you want to place your index finger to the back of the flanges, and you want to rotate the tube just a little bit and straighten your index finger in order to disengage it. As soon as it's disengaged, you want to invert it 6 to 8 times. That is to mix the blood in the tube with the anticoagulant. You then want to release the tourniquet by pulling it gently up. You pick up your 2x2s, you come over here, and I do not like placing the 2x2s directly over the needle to pull the needle out. It puts excessive pressure on the needle. It also has the potential for sticking the needle through the 2x2s. So I like holding it back just a little bit to the side, removing the needle, having the needle come over, 2x2s go down, your thumb is holding pressure, and the OSHA approved safety device right in this area is engaged over the needle. Do not reach up like this. Again, you're going to stick yourself with a needle that has been contaminated with the patient's blood. Engage the OSHA approved safety device. Once the 2x2 is over the wound, you ask the patient, do you see where I'm placing the pressure? Do you feel how much pressure I'm holding? Patient responds, yes. Take your fingers right now and place them directly over mine. Hold pressure. Do not look at your wound. Hold it for at least 3 to 5 minutes. And do not look at the area. I will tell you when to look at it. And the reason is, I want them to hold pressure for 3 to 5 minutes in order to make sure that hemostasis is adequate. Most phlebotomists will not do this. Within 30 seconds, they have some type of a dressing, Coban, or tape on, and the patient's walking away. That is incorrect procedure. Pressure needs to be held for 3 to 5 minutes. And it's really not the patient's responsibility, it is your responsibility to make sure that goes on. The other thing that patients get used to is bending their arm up. Never have the patient bend their arm up once a 2x2 goes down. The reason is the vein will begin to roll. You're holding pressure here, but the vein's over here. And what happens? You bleed under the surface of the tissue, and you create a large hematoma, a large kind of unsightly bruise. So you want to make sure that adequate pressure is held, and after 3 to 5 minutes, here's what you should do. You should pick up on an area, a very tip of the gauze. You should look to make sure that hemo, blood, stasis, control has been achieved. You put it back down. You should also look for mounding of tissue. If you ever notice tissue that is pushed up or look like it's mounded, okay, kind of like a little mountain or a little mole there on their arm, that can mean they're bleeding underneath the surface. And if that is true, if you notice that, like mounding, you want to put additional pressure for 3 to 5 minutes. It's possible that you could even have nicked the brachial artery. So make sure that pressure is adequate, and make sure at the end of that 3 to 5 minutes, you're making sure that stasis, no bleeding, is observed, and that no mounding of tissue. If there is none, you will take your Coban, usually a stretchable type of bandage. You will roll around the arm. I usually have the roll coming off the bottom. You roll it around the arm. You're going to bring it up over your last piece, okay, and gently press down. And then, after your draw, and after the draw is over with, you don't want to just have the patient stand up. You want to observe the patient for pallor or paleness, for diaphoresis, sweating, for tachypnea, rapid breathing, for tachycardia, a rapid pulse. You also want to make sure that the patient doesn't have any unusual statements. Geez, I feel a little nauseated. I feel a little queasy. Does it smell funny in here to you? Gosh, is it kind of warm today? And what is your response? Well, sure, it's 110 degrees outside. See you later. You give them the high five, right? You want to kind of make sure that that patient isn't going into a syncopal episode. Syncope is fainting, and it's very, very easy for them to elicit the 7th cranial nerve, which is the vagus nerve. And when the vagus nerve kicks in, okay, the heart rate slows, the blood vessels dilate, the patient does not get enough blood and oxygen to the cerebrum, and the patient passes out. So always make sure that you've not only observed the wound, but that you're observing the patient. And I would ask the patient several times, how you doing? Fine. Now seriously, how you doing? Once your dressing has been applied, make sure that your patient does not lift anything heavy for at least 1 hour, and that this dressing stays on for at least 15 minutes, because the patient's intuition is they'll walk out of the door, they'll rip the dressing off, throw it away, they'll be touching the wound, touching other things in the hospital, and again, we have cross-contamination going on. So make sure that your patient teaching is a key quality, okay, to phlebotomy, not just drawing blood, but instructing the patient what you want and how you want them to achieve those goals. So make sure that they do not lift anything heavy for at least an hour, because that will start bleeding again if they do. And make sure that that dressing stays on for at least 15 minutes, okay, after this draw. Also tell the patient if they have any questions, if they have any concerns, let them know how to get back in touch with you.